Hi, welcome to Case of the Day, and today is Tuesday, and we're on our 41st case, and it's a very simple one discussing one sign, the straight edge sign. This is a 54-year-old known to have Sjogren's, came for a follow-up CT, and you can see here that there are reticular opacities, there's traction bronchiectasis, there's a little bit of subpleural sparing, there's temporal and spatial homogeneity, and there's basal predominance. And you can see here that subtle subpleural sparing on the axial and sagittal images. So this is a classic fibrotic NSIP pattern consistent with Sjogren's ILD. But when you look at the coronal and sagittal images, you see the straight edge that separates the abnormal area from the normal area. This normally doesn't occur with the non-connective tissue disease ILDs. And it's a sign that confirms, or it's kind of a confirmatory sign of a connective tissue disease ILD. First described by Jonathan Chung and colleagues in 2018, and their paper actually looked at three signs: straight edge, exuberant honeycombing, and anterior upper lobe sign that could help differentiate UIP due to connective tissue disease from UIP due to other causes, especially IPF. But the straight edge can also occur with fibrotic NSIP, as we saw here, and may portend a possible progression to UIP in the future, though we're not very sure of that. Why does the straight edge occur? This is taken verbatim from the authors. It is possible that because of the peribronchovascular axial distribution in NSIP cases, as the disease extent increases, it may extend to the lateral margins and produce the straight edge. So we had access to some of the older scans of this patient. On November 13, we have an acute presentation with a mixed NSIP OP pattern, but stabilized by June 15. And you can see that there's been very mild progression since then, but the traction bronchiectasis has increased. Look at the beautiful subpleural sparing in 15 here. So this was an NSIP, and now you see an NSIP pattern, but you can see how the disease has progressed more towards the periphery and laterally. And like a wing, it probably is the reason why we get the straight edge sign. So we're still not very sure why. But when we see these sharp margins and edges, like even here, differentiating normal from abnormal lung, so unless you see air trapping, this would mean that there are sharp margins, and it's the straight edge is a type of sharp margin that occurs with connective tissue disease ILDs. So while this is nice to know in CTD-ILDs, I mean, it's not going to add anything more in a known CTD-ILD. Its role is in identifying possible CTD-ILD in patients who present for the first time with a fibrosing ILD without a known diagnosis of connective tissue disease. Which also means that in every patient with a fibrosing ILD, when we are reporting these, especially those under 60, it is worth looking at the sagittal and coronal images very quickly on the workstation. The way I do it on Osirix is just take the volume and look at it with 3D orthogonal, so you have axial, coronal, sagittal scrolling together. It takes about 15 to 20 seconds extra, but if you see a straight edge in that setting, then clearly you can say in the report that please investigate aggressively for connective tissue disease. That's the Leadership Summit, that's my WhatsApp channel, and thank you so much for viewing this.